Welcome everybody to the latest episode of the Interventional Endoscopist podcast. I'm your host, Win Couple Suchdev, and today I'm doing an interview with a good friend of mine, Scott Haack. Scott, nice to see you, and thanks for joining us.
Good seeing you as well. Thanks for the opportunity to join you.
Yeah, so Scott's really a really great guy that I had the opportunity to meet when he worked with U.S. Endoscopy when I started my career in 2010. He is a serial inventor and an innovator in the world of endoscopy, and is basically from the Cleveland area. He went to college at a university called Malone University, and then was a chiropractor after studying at Logan University. Following his career as a chiropractor, he entered the world of med devices and med sales, brief stint with pharma, brief stint with Medtronic, and then his career just took off with U.S. Endoscopy. Now he's presently with Microtech. Scott, why don't you tell us a little bit about yourself?
Yeah, absolutely. So this is my actually second podcast that I've ever appeared on. I appeared on one after I was on that TV show, Driver versus Driver, back in 2018. It was a group out of New York that had me on their podcast. So this is only the second time I've ever done this. So again, I appreciate you inviting me. Yeah, I hope I can live up to the expectation with all that distinguished guests you've had. But so I had the pleasure of growing up in Canton, Ohio, which is the home of the Pro Football Hall of Fame. So it's the hotbed of football. And I started playing tackle football at 8 years old. And there's a lot of studies that say that that's too early for tackle football. And it probably is, given the brain is still developing at that age. But if you look at the data, really, the kids that are suffering the most concussions are soccer players due to heading the ball, even more than football players. So that debate is still up for discussion. But so I went to, as you said, college in Canton, Ohio, at Malone University. We actually had our first football player go pro out of Malone. Ashton Doolin. He still plays for the Indianapolis Colts today. So I'm a Cleveland Browns season ticket holder, have been for over 20 years, but I have a tendency to root for the Colts every now and then because of Ashton. So I graduated with a degree in sports medicine and a minor in chemistry. And as you stated, I went on to Logan University in Chesterfield, Missouri, and I was in private practice for 10 years as a doctor of chiropractic medicine. I used to treat the pro wrestlers, the MMA fighters, some rock bands. So that was the fun part. The not so fun part was the workers' comp, the third-party payer systems, and the personal injury cases. So I love treating patients. It was just getting paid for those services that I didn't like.
So what made you kind of change directions in your career? I mean, you still stayed involved in healthcare and medical field, but you went from clinical practice to working on the industry side. So what kind of had you go in that direction?
Yeah. So when I was in private practice, I started developing products that went to market, and whether they were a seatbelt device that redirected the seatbelt over the hemoport, portacath, pacemaker, defibrillator, implants. Because in my practice, I found that a lot of patients weren't wearing their seatbelts, or they were putting the seatbelt under their arm because the seatbelt was rubbing over that area. And I thought, oh, that's interesting. But my wife, who's a cardiac nurse, we were coming home from church one day, and she said to me, you know what you need to develop is a product that redirects the seatbelt over the implant of a pacemaker, defibrillator, or portacath. And then the light bulb went on.
Yeah.
And that's when I came up with a device that we end up selling to Pressure Products then, which was a bigger company that could get it to the market faster than I could. But one of the first products I ever developed in private practice was a bridge device. I started noticing that the patients that came into my office with more disc problems than others were people that had a hypolordotic spine. So they had a reduction in the lordosis of the lumbar spine. So, I could change the juxtaposition of the vertebrae all day long through manipulation, which helps because it actually gives an equal wear pattern on that disc. But really, in these patients, we needed to change the dynamic structure of the spine. So I developed a bridge that once I got the patient down to about a 4 or 5 on a VAS scale, a visual analog scale, I would put EMS on them to soften the tissue as they laid on this bridge. And we were changing the sacral base angle from about 20 degrees, which is a pretty straight spine, to 35 degrees. I was taking before and after x-rays. And so we were really changing that dynamic structure of the lumbar spine. And patients that they carried into my office, 4 or 5 months later, they were playing golf again. So it was pretty amazing. Yeah.
It's actually interesting. When you talked about the seatbelt device, I didn't even realize that existed, but about 3 or 4 years ago, I had to have a robotic surgery on my chest. I had to have my thymus removed. And so I have this big scar kind of under my rib cage, kind of around the nipple line. And after my surgery, I couldn't wear a seatbelt either because it would come this way and it would just hit right there. And I literally was actually not even putting it on my armpit. I was just putting the lap belt on and throwing the other side behind me. Obviously not very safe, but I wish I knew about it then because I can totally understand how when you've got something in this line of your body, a seatbelt can really irritate the out of it. So that's actually fascinating. So, yeah. And then the spine part, that people love playing golf or whatever activities, and just to be able to get back to that action is great. So how did you end up at GI?
So, luckily, I've been in GI for over 22 years. I started off in GI with TAP Pharmaceuticals doing phase 3 drug trials with the drug femuxostat, which is a gout drug. So I was doing phase 3 drug trials with them. So that started my GI introduction. And then I got hired by US Endoscopy, Dean Seacrest, Ruam Khan, Tony Siracusa, Bill Busby all took a chance on me and brought me into US Endoscopy in 2006. And I started developing products at that particular time. So Dean Seacrest was really my mentor at that time. And he was a big time inventor in GI endoscopy. He was one of the original founders of American endoscopy and US endoscopy, along with the original founder, Marlon Yonker. And so the thing I love the most about Dean is he allowed me to be me, right, and encouraged me to be my best. And a lot of times people become resentful for someone else's successes, and right, he never did. So he just gave me free rein to come up with whatever I wanted to come up with. And, we came up with some good stuff at US Endoscopy.
And so for the audience, like, what are some of the things that an interventionalist, and that's, obviously most of the people who are tuning into this podcast are interventional endoscopists, but what are some of the things that we're using today that you had a hand in designing or a major responsibility for designing?
Yeah, so I mean, the one that sticks out in my mind is the Mori Micro Forceps. And that product, not only does it distinguish mucinous from non-mucinous and benign from malignant, it helps you subtype the cyst as well to determine whether or not it's oncocytic or pancreatic or biliary or intestinal or gastric metaplasia, which, as you know, better than I, that each one has its own malignant potential. And there's some incidents that we've seen an uptick in pancreatitis, but I kind of look at what we do for ERCP and prophylactically using rectal indomethacin as a drug to prevent the incidence of pancreatitis. I don't think we've looked at it enough for EUS yet.
Back to my knowledge, no. So,
and I think that's one area that we could probably improve upon, especially when we know we're doing work in the pancreas, because we know the pancreas is an angry organ, so any kind of manipulation in that organ or something that it doesn't like it kind of shuts down and the ducts close up and pancreatitis occurs. So I think really looking, especially if you're using the Mori microforceps, if you want to really diagnose that cyst, that it would help to use rectal indomethacin prior to that procedure to make sure that the incidence of pancreatitis is as low as it possibly can be.
Absolutely. So for anyone listening who's in a research capable institution, there's your idea. So, yeah. So also, I guess you made the change, about 5 years ago or 6 years ago from US endoscopy, and then you had like a 1 or 2 year kind of gap, and then over to Microtech. So talk about what your role with Microtech is now, and how you got involved with them, and what you're doing, and what you guys have come up with so far.
Yeah. So I'm the executive global R&D director for Microtech. And as you stated, I started about 5 years ago. I was with US Endoscopy for a little over 11 years, had a little hiatus, and then Chris Lee brought me into Microtech in 2019. And so my role is collaborating with physicians with their new ideas and bringing their ideas to market, and also coming up with my own ideas to get to market as well. Good thing about Microtech is that they are a true innovative company. They're that draw your invention on a napkin type company, and we will build it. US Endoscopy was like that back in the day as well. And I always talk about, we always talk about the American dream, and we look at like Shark Tank, and we say, oh, that's the American dream. You get on Shark Tank and get one of the sharks to buy into your idea.
Right.
And really, that's not the American dream, because a lot of these people have mortgaged their home. They've taken their retirement and put it into this product. And if it doesn't work, they're in trouble. Really, the American dream is what Dr. Bennett Roth did with the Roth net. And he literally drew what he wanted on a napkin, and it became a $25 million product a year, Yeah. So, I mean, that's the American dream. He didn't sink a dollar of his own money into this product and then benefited in the end. So to me, it's finding that right partner. It's finding that right company that you can build your product with and then launch it to the market. So that's what I do. That's what I do. I work with the physicians with their new ideas, try to get that particular product to the market. Right. And I work with a lot of physicians and nurses and techs, and also I come up with a lot of my own products as well that I can't talk about. Some I can't talk about right here.
Yeah.
But the good thing about Microtech, and I'll add this as well, that they're a rare company in that if a product is innovative and needed, but yet maybe doesn't fit within the core competencies of Microtech, they will still find a way to do it.
Yeah,
which is unheard of. So Microtech is doing what the companies used to do in the past that are kind of avoiding now.
That's I mean, and I can attest to that a little bit, because to one of my partners and another colleague of mine, both who are in Arizona, have worked with Microtech to bring their products to a significant advancement point. I don't really know if I'm allowed to talk about those, so I'll just keep my mouth shut at that. But I personally know 2 physicians who worked with the company to bring their products to the point where they could be realized at some point, and it is a unique perspective, seeing that happen. One thing I wanted to ask you about, and before we get a little bit, and I know we're going to talk a little bit about some of the products that you're working on that you're allowed to speak about, but a couple of things I wanted to ask you about. Number one, I wanted to give you a second to talk about just for people who are curious about any of the non-medical inventions outside of the seat belt clip and the lordosis device. Some of the other things that you've designed that are just kind of cool facts. Like I was wanting to hear a little bit about the golf driver and the putter, and the watches you made and some of that stuff. I think it is just fascinating for people who don't know you to learn a little bit about that stuff.
Yeah. So I'm always working on new stuff outside of endoscopy. It's amazing how direct products complements what I do for microtech. I mean, there's always things you can take from one and apply it to something else. It's really unique on how that works together. So, I did the same thing when I was at US Endoscopy and Stairs. I was always working on and tinkering on stuff that was outside of medical, outside of endoscopy as well. So it keeps you fresh. So I appeared on, as you know, and you alluded to it, I appeared on the show Driver versus Driver on Golf Channel back in 2018 with a golf driver that I actually had two designs, and I only had 6 days to submit my design. I had one that was a traditional design that I thought could win, but I thought it might not even get me on the show. And then I had this radical design that I thought, if the industry is ready for a change, this could be it. And then I might win, but I'm definitely getting on the show. So I thought, what is my goal? My goal is to get on the show. So I went with this radical design. I didn't win, but I was on like 4 episodes. So that was
yeah. I remember watching the.
Yeah. It's the first time I've ever had makeup on my face. So at the end of the night, I'd wipe, this makeup off my face. Now I know what my wife and my daughter go through, So I guess I have a new affinity or sympathy for what they go through. So I came up with a unique and novel luggage concept that drastically reduces the strain on the user and also reduces the vibration on the inside contents. And I haven't got into it yet, but I'm a big Disney nut, I'm a big Disney fan. So I came up with the name Droid, and the USPTO allowed for this name.
Wow.
And then I got a cease and desist letter from Disney that I could not use the word droid for my luggage, even though they didn't have it protected. So I did not fight Disney. So that's one advice I would give to new inventors is don't fight these larger companies. Just find a new name. So that's what I did. But I showed this luggage concept, and I won't mention the name of the company, to the president of an extremely large luggage company. And he told me at the time that your luggage concept is a lot better than Pelican, and it is made for all consumers, not just a niche. So he concluded what they needed my product desperately. But when I contacted Pelican, they wouldn't sign an NDA. So that's another advice I'll give to those inventors that are out there, that if they won't sign an NDA, don't reveal your product to them. Just run away from those companies that won't sign an NDA.
Absolutely. Yeah. Because otherwise they'll just steal your idea. So.
Exactly. Yeah. So, and then I've come up with this surface temperature dog walking system to prevent dogs or pets from getting damage to their paws. Wow. On surfaces that absorb heat. So it constantly gives you the temperature. Because when you're walking your dog, you're not walking your dog in bare feet, so you don't know what they're going through. It could be 78 degrees outside, but the temperature could be 110 on the surface that they're walking on. So there's other products, but these are the ones I'm working on right now.
That's awesome. Yeah, actually, that's something that would do great in Arizona, because I mean, we joke around about how hot it gets that you could cook an egg on the sidewalk, but it's actually true. In fact, I know of people, because it gets so hot in your car, for example, that they'll put cookie dough on a little tray and put it on the dashboard, and they come back, they have fresh cookies. So, and I'm not making that up. People that actually know.
I just saw that. I just saw it. I think it was Facebook or LinkedIn. Someone had, or Instagram, and had posted that. I saw that.
Yeah. So when we walk our dog, we wait till we still have some sunlight around 7:45, but we wait until about 7:45 or 8, because if you go around 4 or 5 in the evening, The outside temperature is probably like 2 weeks ago was 116. And so the asphalt on the sidewalk is going to probably be closer to 125 or 130. And I don't personally know what a dog's tolerance is, but I mean, I would, like you said, I wouldn't walk barefoot on it. And I think that would hurt him, really bad. So those type of things. So it's really cool that a lot of your innovations are really just solving everyday problems for people outside of the medical field. Yeah, that's great. Is there any other advice you would give to new innovators or people who are looking to maybe, many of us physicians or endoscopists, we always look at our tools and say, well, this would be better if we did it this way or that way. And, each of us probably come up with one or two ideas in our career at least. And any advice for those guys who want to bring something to maybe you at Microtech or another company, like how would you go about it and how do you get involved in that world?
Yeah. So that's an interesting question. And I guess I'll start with a quick story. And I mentioned Disney. I'm a big fan of Disney. This is a Walt Disney story. So his first ever invention was Oswald the Lucky Rabbit. Right. And he didn't have the resources to get it to the masses. So he partnered with Universal to get it to the masses. And it did really well his first year. So he was living in California and he got on a train, went from California to New York to renegotiate his contract with Universal since Oswald the Lucky Rabbit did so well. And once he got there, they said to him, you didn't read the fine print. You don't own Oswald the Lucky Rabbit. We do. Mm-hmm. So instead of getting upset and saying, you know what, my career is over, this is the best chance I had, by the time his train got to Chicago on his way back to California, he had already invented Mickey Mouse. So the moral to the story is you're going to hear no about 95% of the time. And you can't focus on that. You got to focus on the 5% and making that game changer. I mean, no one ever heard of Oswald the Lucky Rabbit again.
Right.
But everyone heard of Mickey Mouse, and Walt Disney even said, just remember, it all began with a mouse. So, I mean, that's one of the big things that I can say, that you're going to hear no 95% of the time, but really you got to shoot for that 5% where you're going to get yes. So first, learn as much as you can about your concept, the benefits, the shortcomings, the market need, the need to have features versus the nice to have features. A lot of times we design products around nice to have features.
Right.
And that ends up driving the product when you really don't need that in the beginning. You just really need the need to have features, because what ends up happening is those nice to have features are so complex that it keeps you out of the market longer than what it should. So just focus on those need to have features and then build a skunkworks prototype, something that's not that expensive, but really tells the story. That whole skunkworks prototyping was developed from Lockheed Martin. It was an old Lockheed Martin term on a startup development from a prototype. So build a skunkworks prototype, something inexpensive that tells the story and that you can get feedback on. The third and fourth thing kind of run together, but I say third, protect your idea, then what you learn about it, and you learn the ins and outs and the features that are novel. File a provisional patent if you want, trademark it. But if you find that industry partner, that trustworthy industry partner that believes in your idea, believes wholeheartedly in what you're trying to do, then they will file that patent on your behalf. Microtech does that. Microtech, when they're working with a physician, there's always subtle nuances that make the product work as you go along that the physician or the inventor didn't see early on. Right. And there's something novel that comes that way. Microtech, what they'll do is they'll file that patent on your behalf. You're still the primary inventor on that patent. But those that were contributors to the patent will also be on it as well. So if you can find that trustworthy industry partner to file that patent on your behalf, I would say do that. But always get an NDA. You know, that's the one thing that be leery, because it really attests that company.
Right.
If they say, no, I'm not going to sign that NDA, then you need to find another company to pitch your idea to. You know, we will always sign that NDA to have that mutual conversation between the two.
And for those listening who aren't familiar with an NDA, it's a non-disclosure agreement, basically saying that you're not allowed to talk about this idea except for what we talk about in the room. So it protects you as the person with the idea from the company talking to other people about it or somebody copying your idea. So it makes it a private conversation. And a lot of times when you do work with the industry and they'll show you prototypes, they will ask you to sign an NDA so you don't go tell a competitor that, hey, Microtech or Boston or Cook is working on X, Y, and Z, so you should work on it too. So that protects everybody in the room.
Yeah, exactly. And that's a great point, because there's times we have to show what we're working on as well, because sometimes it's similar to what they're working on. So we have to disclose, look, we've kind of been down this road for the last 2 years or something like that. And the other bit of advice I would give, and I love using these 3 words, and it's simple, intuitive, impactful. And if your product is a simple solution to a known problem, it's intuitive in its function, which means every time you pick it up, you know how to use it.
Right.
And it's impactful in its results. 9 chances out of 10, you got a winner. So it's that simple, intuitive, impactful, and it really has to solve a problem, because there's so many inventions. Just because you can doesn't mean you should.
Right.
It should really solve a problem, you know?
Yeah, absolutely. And there's a lot of products out there that we use every day or every week that are very impactful, but they're not simple and they're not intuitive. You know, like you have to pull out a YouTube video if you know, and remember how to set something up. And sometimes it's necessary evil. You know, you have to do that. It's just the nature of the beast, but it does get frustrating. And I've been in cases where there's a product I want to use, but I'm like, you know what, screw it. It's too complicated. I'm not going to ask my tech to go through it. And in fact, I mean, just to say, like, when Spyglass Legacy came out, I think one of the rate limiting steps that Boston faced with people using cholangioscopy was how complicated the setup was before the digital version. Once the digital version came on, it just took off. And, you know, obviously, cholangioscopy's, you know, been around for 15 years, 15 to 17 years now, and it's just starting to take off over the last 2 to 3 years. So it's simplicity, ease of use, and impactful. I completely agree with you on that. So before we also, I know we're going to talk a little bit about some of the inventions, but one other thing, you know, in GI, you've now been involved in gastroenterology for over 20 years. You've seen from when you started US endoscopy, something as simple, or maybe not simple at the time, but simple as a rod. And now you're seeing artificial intelligence, and you're seeing, you know, complex algorithms, you're seeing cholangioscopes and different devices, disposable scopes come out. Number one, what do you see as the next wave as an innovator? What's the next wave of growth in GI? And number 2, what are you most excited about seeing? And number 3, what's on the horizon as far as you can tell where GI is going?
That's a loaded question.
Let's start with the simple one. What are you most excited about?
Yeah. Well, you know, and I'll start with this. I remember 12 years ago, when I was a US endoscopy, an engineer said to me, well, there's nothing left to invent in endoscopy. And I remember saying, you know, well, we should just pack up and go home, you know, and if you look, you know, the invention of the Axios Lamb's stent is probably one of the biggest breakthroughs in the last 25 years in endoscopy, you know, and I think there's a lot of products that have come in the past 12 years that have been good products as well. So when you look at the field of GI endoscopy, to me, it's limitless. I believe the advancement of the field is directly proportional to the tools the endoscopists are given. It allows the physicians to take more risks. I mean, if you remember, 15 years ago, you guys didn't want to see anything bleed. It's like any bleeding at all. It was like, no. Now you want to see it bleed in front of you so you can treat it appropriately. And so I think as the mind changes, I think the procedures are changing a little bit. I think the mind is changing a little bit based on the tools that you're comfortable using during these procedures, that you can take care of it. And you don't have to ship them to surgery to take care of this problem, that you can take care of that problem directly in your lab without having to transfer that patient. I think that's key. I think we're getting into ESD. We haven't even got to the limits of what ESD is going to be. I still think EMR outside of the rectum accomplishes just about everything we need in the United States, at least. But ESD opens that door to take everything on block, get that healthy margin, and make sure that there's nothing left behind. I mean, and that's very important. So, you look at the cool tools. The cool tools really are in interventional radiology. They're in cardiology. But I'm starting to see those tools find their way into endoscopy as well. And we're starting to become a leader in those areas. I mean, you look at what Dr. Chris Thompson and Brian Tinkham are doing. I remember back in the day when they were known as B Corp, and now, they're Beacon, and they've sold that, and what they're doing with GI Windows. And you look at what Dr. Carlos Robles is doing down in Ecuador, with his AI platform and his virtual goggles and the capabilities that come along with those. And you look at the EndoRx team with, Dr. Reichman and Kristen Springs in the projects they're supporting and that they're coming up with. I look at Novascan, and this is an interesting one. If this product could standardize rows, this would be a huge advantage for us. I mean, this product could really bring everybody up to a standard to those that have done that have had really an on-site pathologist for the past 15 years. Not everybody has that luxury of having that same pathologist for the past 15 years that you trust. I really think that Novascan, once they get their algorithm narrowed in and zeroed in, I really think that product could standardize rows for all labs and all institutions across the world, which you wouldn't then need an on-site pathologist that has 15 to 20 years of experience.
That's the problem we face in our setup, because we don't have that luxury. So,
right. And the turnover. I mean, it's with anything, whether it's physicians or nurses or techs or pathologists, there's a lot of turnover nowadays. So by having that standardized approach in rows through Novascan, that could bring everybody up to a certain standard and then allow for diagnostic capabilities to be enhanced. So I really think that's an exciting product. And you recently had on your podcast Endosound, and I think that's the logical next breakthrough in EUS. As EUS continues to grow, it's expensive, and everything, we were cutting costs. And this is one of the few, I would say, novel examples of a cost-cutting measure to where you're not cutting the innovation out of it.
Absolutely.
The visualization is phenomenal. I was one of the first to test it about 3.5 years ago in our lab at Case Western Reserve University here in Cleveland, Ohio. And I know you know that well because your daughter's going to be playing soccer there here this year. But we tested it about 3.5 years ago, and I was really mostly concerned about the visualization. And we had it on a little monitor, and the visualization was great. And I said, "Hey, do we have another monitor?" And they said, "Yeah, we have like a 60-inch TV. Well, bring that in. Let's test it. Let's hook it up." I wanted to see if it pixelated in a bigger area, and the visualization and the optics was just as good on that big screen as it was on that little screen. So it never pixelated. So from that standpoint, the EndoSound product to me is a really exciting product in the marketplace, and one that we can grow from.
No, it's a game changer. I mean, just for something, their first iteration that most of us are getting our hands on, I mean, is so good that you can only imagine what 1 year down the road or 2 years down the road, with more investment and more higher end technology as it goes into what it's going to look like. And actually, I think it's the future. And you and I have talked offline so many times about ambulatory surgical centers and what changes we can bring in there. And I think this is a true disruptor in EUS, at least, or in interventional endoscopy. And I think my biggest fear is that if they, or whenever they get acquired, that whatever company gets them shelves it in order to sell their main platform. And I hope that whenever they get to that point of their evolution, that the company gets them is really committed and puts all the resources into making this, because I mean, at least 60 to 70% of our endoscopic ultrasounds do not need to be done in a hospital. Where the cost, EOBs, like I said, podcasts are anywhere between $10,000 to $20,000, depending on what they're doing. And, you can do it for Medicare rate of $832, so,
right.
So, I mean, I think our country, and we're not getting into politics here, but we spend more money than any other country per capita on healthcare here. And we don't need to be doing that. We can do things much more efficiently and much more cost effectively, and get better outcomes too. So.
Totally agree. All
right. Well, I think as we were talking, a lot of the reasons why I wanted to interview Scott came out in the things about, his unique journey from, chiropractor to, taking care of wrestlers and basketball or football players and athletes, to becoming, I think you spent 1 year as a drug rep as well, right? Or was it only?
So I spent 1 year in sales, because I thought that's the one thing I had a lot of clinical experience, but I had no sales experience. Right. And I thought I need that going forward. So I spent 1 year doing that, and then the rest doing phase 3 drug trials.
So from football player to chiropractor to sales rep to inventor, and probably always been an inventor, innovator throughout your entire life, but to now becoming, where you are at Microtech with development. So Scott is actually going to talk about some of the inventions he has, and we're doing this podcast simulcasting on audio as well as video. So we're going to have some videos. So if you're just listening to this podcast, what I'll suggest is that there will be a link to the YouTube video, and then you can watch it again or fast forward to this point in the podcast, and I'll put the timestamp in the description so that you can go and see what he's talking about. So Scott, I want to let you share your screen. Let me just make sure we have that capability. I think you have that permission. So I'll let you have the floor and show what you wanted to talk about.
Okay. See if that pops up.
Yeah. Great call. Perfect.
Okay. So as you're probably aware, we launched our new IMAX cholangioscope system this year. We have a couple versions, which is the 11.7 French, which is a 3.9 millimeter outer diameter, has a 2.0 millimeter working channel. And then we have a second one that is a 9.6 French, which is a 3.2 outer diameter. And then we're also working on a 7 French version as well. But with the 2.0 channel, it allows for larger instrumentation, like a larger EHL probe, or we actually have a larger, 1.6 millimeter biopsy forceps that fit through the larger IMAX system as well. And all units have visualization capabilities greater than 160,000 pixels, which is about, 40 to 50,000 pixels more than the cholangioscopes that have been developed previous. So we have a special CMOS chip that it enables that to be, for that visualization to be carried out. So as you can see in some of these pictures of the cystic duct and, the bile duct stones and the polyps, even in the gallbladder, which, I mean, pretty rare in bile duct cancer. But you're able to see that through this system. And I really believe that this is going to enhance what we do going forward. I can't get into some of the nuances that the team in China is working on, but they're working on enhancing this product to even do more than what you currently see here. The second one is the DAT closure device, which I'm sure you've seen. I'm going to cover three of the first products are going to be ones that we've already launched. But this is probably another device that you're familiar with, which we launched in 2023. This was really the first through-the-scope large defect closure device that functions similar to the twin grasper, only it brings the margins together, but the difference is that this one deploys like a regular clip. Mm-hmm. The twin grasper is a nice grasper in bringing the margins together, but this one brings the margins together and then deploys. And really, when you think about it, this is really probably a safer option to use with the over-the-scope clips as well, because if this device gets entrapped by that over-the-scope clip, you can fully deploy the grasper or the end effector, the clip part of it, away and be able to remove yourself from that situation. We've had situations in the past with the old twin grasper where it didn't get fully out of the way,
right,
and deployed that over the scope clip and then entrapped everything together. Now everybody goes to surgery, the scope, the clip, the patient. This way you can use this as a twin grasper, and then if that happened and you didn't get that grasper out of the way and it clamped on it, you could actually deploy this,
right,
and then have to go to surgery. So really, this is, even though it's a large defect closure device and bringing the margins together, it really is a safer option in using with the over-the-scope clips as well.
No, that makes sense, actually.
So the other one is the lesion hunter. I don't know if you've used this cold snare.
It's pretty much the main snare I use these days in the ASE. So I'm using the 10, and we've used the 15s, but I'm using the 10, and I love it. The rotating ability is really good, and the way it cuts is really nice as well. So
yeah, the 0.018 millimeter nitinol wire enables you to cut larger lesions, not just diminutive polyps. Anything can cut a 5 millimeter diminutive polyp. Right. But when you start getting into that 1.0, 1.2 millimeter lesion, what are you able to use that can cut cold through that amount of tissue?
Right.
And really, when you look at this, so the first picture was a one of the human uses in human use that we used with Dr. Rex. This one was actually filmed in the lab at Case a couple weeks ago. And as you can see, I used a lift and cut with a grasper. Look how deep I get with the lesion hunter into that piece of tissue.
Right.
And then you're able to cut that big piece of tissue then cold. And I always say, that we're asking this snare, to really do more work. Work equals force times distance. We're actually asking this snare to do more work than any other snare on the market, due to the amount of force that it takes to get through this level of tissue and the distance traveled to get through this amount of resistance on the tissue that you're resecting. So we're actually asking this particular snare to do more than any snare that's ever been developed, because it's getting no help from a electrocautery or electrosurgical unit. And this thin wire is what is cutting through this large piece of tissue by itself. So it's been very, it's received great feedback in what it's able to do. And as you look at that defect, you have a hard time creating that level of defect with any other cold snare. Braided snares have a tendency to rip and tear a little bit. The nitinol snare cuts through very clean, as you can see the margins.
Yeah. And it just, I mean, my 2 cents on it, this is a snare that I think when you do use it, just to have your tech cut slowly, the slower you go, I feel like it cuts better. If you have somebody who just kind of goes real fast, there's a chance, and I think it's a safety mechanism in the snare where it can snap, right? Or there you have some kind of safety built into it so that it doesn't. I think it's supposed to break off or something, like if it's too much tissue. I'll let you say, because I don't know exactly how to.
Yeah, you know what? If you engage muscularis, I mean, from the standpoint that the muscularis, appropriate is a very, very thick and dense piece of tissue. If you reach that level, the snare will break before it will cut through that particular piece of tissue, which you don't want to happen. Right. So it's built to do that to a certain degree. We actually have an enhanced version that we're working on right now to even advance this platform even further. So stay tuned on this one as well. I'm also working on another tool. This is kind of the first step, and then we take a little larger step with the version from the Lesion Hunter that we're coming out next. And then there's another version that takes cold snaring to a whole new level that I can't get into right now.
Yeah, and it's important because I mean, I started my GI fellowship in 2006, and I started working. My therapeutic fellowship was 2009, and I started working in 2010. And just from 6 to 10, or 6, the use of hot snare went completely the opposite direction. So I think 2010 or 11, cold snare has just started to go up. The data is showing it's really good. And now that people are doing underwater EMR, cold snare is probably really good for those type of lesions. So it's just, it is an integral part. And I think investing in cold snaring is, because I mean, we talk about snares, right? I mean, at the end of the day, it's a lasso that you're going to use to cut off a polyp, right? And if you ask somebody 5 or 6 years ago, really, how are you going to innovate the snare better? And, people come out with different shapes, and, this one looks like a hexagon. This one is like a C with a straight line. And there's all these different shapes. And the average end user, the average gastroenterologist or interventionalist is like, I don't really care. Just give me something that gets around the polyp and it's going to cut through. But now that we're going for more cold and we're going for more bigger resections, it's important that that innovation is happening to cut differently or cut better, so.
Yeah, absolutely. And I'll add to that as well. And, I hear some people say, oh, it's just a snare. But when you think about it, the most trusted tool of the endoscopist is the scope. What's the second most trusted tool? Probably the snare. What Hiromi Shinya developed back in the day, think of the lives that he has saved from just developing that snare. I mean, without that snare, patients are getting hemicolectomies.
Right.
So you think about it, with the snare, the patient's life yesterday is the same life as it is today.
Right.
With the hemicolectomy, the life that they experienced yesterday is totally different than the life it is today. Absolutely. So when you can innovate in the snare market with something that is really impactful, not only to you, the practitioner, but ultimately to the patient, you're making great strides in preserving that patient's life from that point forward.
Absolutely. Absolutely.
So it's a good segue, because you talked about cold snaring. Now we're going to get into hot snaring.
Yeah.
So this one is new. We just launched it. It's called the Edgehog. This is really the new kid on the block in that we just launched it. The Edgehog has a flat wire monofilament snare. We use stainless steel in this one. Nitinol is not a good conductor of electricity. It's more of an insulator than it is a conductor. So we had to use stainless steel with this one. But it's not a round wire. It's a flat wire monofilament. So it has great column strength and indents well within the tissue. So the column strength and leverage that you will get out of this particular snare is really unmatched. And I'm going to play this video for you. This is one of the first inhuman uses that we had with this Edgehog snare. And as you can see, this is pretty big polyp, broad-based lesion, and this snare is able to entrap and not slip. A lot of times you'll see it slip from the distal part and slide over, and you'll just take what you can get.
Right.
This is a precision instrument in that it grabs and cuts exactly what you intended to cut. And then the last thing I'll show you on this, look at the razor thin margins around the defect. You know, there's limited artifact from the current. A lot of braided snares, you'll see that those heaped up margins.
Right.
And with this, as you can see in the picture to the left as well, look at the razor thin margin that this creates. So it's really...
That is actually pretty impressive. And I know what you mean by the heaped up edges with the other snares. So that is cool.
And I'll show you another way this works. So I call this a heartbeat tweeze. I drew a red line at the top. And as you will notice, it reduces its width before it ever reduces its length. So it moves east and west before it ever moves south. So when you lay this snare down, and as you can see on that middle picture, how the flat wire looks.
Mm-hmm.
And I'm going to play it again. When you first start to close, its first action is to pinch and hold that tissue, not to draw over top of the tissue like you see with braided snares. So that's why you get no slip with this particular snare. I like to call this one an ESR snare, an endoscopic submucosal resection snare, because really it's greater than an EMR snare. You know, we got a lot of braided snares that do the job, but maybe not do the job so well. This is that bridge device that goes into ESD. It's a sub-ESD device in that a lot of times you're going to have to take it piecemeal with this. You can take it on block, as we saw, but most of the time it's still a resection device. It's not a dissection device, but it's greater than that EMR tool that you typically used in the past.
And how did you guys come up with the name?
Yeah. Well,
I've heard of Edgehogs, but I haven't heard of an Edgehog. So,
right. So I've got to tell you, this was supposed. I'm good. Well, I can't say I'm good, but I like coming up with names. There's a lot of bad names I've come up with too. So I came up with the IMAX name. I came up with the Lacado name, which some people like, and some people call it Lacadoo. So you can say that that's good or bad. You know, I came up with, so this was supposed to be the lesion hunter. Okay. But the cold snare outpaced the hot snare. So lesion hunter found its way to the cold snare. I called this one Edgehog because it's a flat wire snare and it has right angles.
Mm-hmm.
So it's edge in grabbing the tissue that you're trying to resect, and also you're able to grab a lot of tissue. There's times when you have to re-grip with this snare.
Right.
And also keep in mind, even though it's a 20 millimeter snare, that you can actually draw the snare into the catheter and make it a 16, and make it a 14, and make it a 12. It's going to keep its shape based on the memory point. So you don't have to use it as a full 20 millimeter snare. You could actually use it as a 16 or a 14 or a 12, whatever you want to use it for.
Right. Very cool.
So then I got two more.
Right, right.
So the next one is actually, non-migrating ink. So it's stable, non-migrating ink. So as you know, all ink on the market migrates. So when you inject it, it either takes up 50 or 80% of the entire lumen because it migrates over a period of time. This one stays in place as a solitary dot once you inject it. We've tested it in over a 30-day period and a 60-day period, and it still stays that solitary dot. As you can see in the big picture, that was the first 30-day study we did in China. And as you can see, the one injection was stable, is that one solitary dot. And then the competitor's ink, as you can see, it migrated probably 50% of that colon wall, which is a huge problem if it migrates underneath another lesion and it attacks it down and you've got scar tissue. And sometimes you got to go to surgery just based on the fact that the ink migrated underneath that polyp. So, as you know, Jeff Ponsky wrote the landmark paper in 1975 on using ink. He was the very first physician to use ink to mark certain areas. And I'm sure that comes from being a surgeon and also an endoscopist as well. But I showed this to him. And as you can imagine, he was very enthusiastic about it. He actually said, playfully, "Oh, this will bring me out of retirement." His wife hit him and said, "Absolutely not." So I wanted to show him the advancement in this area about what we've done in creating ink that stays put and doesn't migrate to a certain area. As you can see, look at the 1 cc. You got 1 cc of stable ink, looks very small. And then you got 1 cc of the competitor, and that's what takes up the entire wall. This is all the same amount of injection in that area. So, and I can tell you, the one that follows this is even more exciting, and I can't get into it. Here's another thing I cannot get into right now. But the product that follows this one, if you look at the 1 cc dot and the 4 cc's and the 8 cc's, they all, no matter what your volume is, stays that solitary dot. So this one will be out this year as well. And then the last one I'll show you, and this comes by way of Dr. Chalk and Dr. Jeff Marks and Dr. Ryan Yuza and Dr. Steve Shomish out of Case Western. Actually, Dr. Yuza is at Wisconsin now. He transferred over from Case to University of Wisconsin. They came up with a second channel that you can use as a second channel. It doesn't impede your progress. It's not like trying to drive a 57 Chevy without power steering. It doesn't cause you to have difficulty with driving the scope. It doesn't impede your ability to maneuver the scope. You don't even know it's on the scope.
Right.
You can use it as a second channel. But what makes this unique, it has a split channel design in that you can retrieve larger items without removing the scope. So if you're on the right side, and let's say the patient has a redundant colon or an alpha or an end loop, and it took you 9 years and a day to get to that right side, and you've got a broad-based lesion that you have to take take that lesion in a piecemeal fashion, you can cut, and then put down a net and grab all of the segments and retrieve it without removing the scope. And I'm going to show you the video here. This was in China with one of our physicians that used it. So as you can see, he removed it from the colon, and then you'll see at the bottom how it tracks up to the scope then. It's almost like me with the camera, but they bring it all the way up to the handle, and then so now you can keep that scope in place and still retrieve tissue.
Amazing. Yeah, no, that's actually pretty. I mean, a lot of these things have a lot of utility, not just in the hospital, but in the ASC as well. And that's kind of where I always look at these things that, yes, we got to use them in the hospital, but we can absolutely use them in other locations. And what do you got here?
Yeah, so this is just the second channel. This is how it attaches to the scope,
Right.
and this is how it attaches to the the flexible end of the scope, and then it's got the split channel, and it all comes up through this middle part that you can retrieve. So, it's really cool from that standpoint, and it's getting a lot of buzz, and so we should have that out in the next year as well. So there's a lot of stuff that we're working on. This is just a sampling of all the stuff that we're working on. A lot of stuff I can't talk about.
Yeah, no, but it's all exciting because, I mean, as I've said in different podcasts before, if you're an interventionalist, or even if you're just, not even if you're just, but if you're a general GI, you're in a field that you use your hands, you use tools, and you're somewhat of a technophile or a tech geek if you're in this field. And I think the more advanced cases you do, the more your mindset is to try new devices or look for the next cool thing. And it's just exciting to see that we're not just doing snares and biopsy forceps, that we have other things that are coming out that are going to help us do our jobs better and in some ways cooler, so I do like that. Well, Scott, I really want to thank you for your time. I know you're extremely busy, but I appreciate you spending a little bit of time with me today. Also, just a couple announcements that I make at the end of every podcast. First one is that, as an interventionalist, it's important for you to join your societies, your ASGE, FIGHT, ACG, ASLD, whatever society kind of resonates with you in your practice. So support them. They can help get the reimbursement for these really cool procedures we do. They can help preserve our practice. So definitely get involved if you're not. And then also for anybody out there who's struggling, mental health is important for all physicians. And even if you're not a physician, even if you're in industry, we all have stresses that we have to deal with. So if you are struggling, get help. And there's a lot of great resources out there. And these days you can do everything on an app or reach out to somebody in person. Scott, thank you again. Really appreciate your time, and look forward to meeting you the next time we're at a meeting.
Absolutely. I'll show you some of the other stuff outside of this podcast.
That sounds great. All right. Thank you, guys.
Please hit that like button and that subscribe button.